Hi everyone, I am Jodie Ann Senior. I'm a cardiologist and heart failure specialist, and today I wanted to talk to you about the Strong HF heart failure trial. This was published in The Lancet in 2022, so relatively recent. It was a multinational, open label, randomized heart failure trial. What does all that mean? It means that it was across a number of continents, countries. Open label just means that the doctors who were doing the trial knew what medications the patient was taking, so did the patient. And randomized means that they took two groups, organised them in a random fashion, or selected the participants in a randomized way, so hopefully in an unbiased way, from a pool of patients that should have been fairly similar across a number of categories like age and sex and so forth. They took patients that were between 18 and 85. These were patients who had acute heart failure hospitalizations, so they were admitted for things like breathlessness, fluid overload, maybe low blood pressure, difficulty breathing or having chest pain, angina, swelling of the legs, etc. And these patients were not yet on full guideline-directed heart failure therapy. They had pump function that was split up into those that had ejection fractions or pump function less than or equal to 40, and then those that were over 40. And then they were followed up for a period of 6 months. Actually, they do have data out to 12 months. There was around about 1,000 patients, so when they were randomized into two groups, they were split into roughly equal 500 patient groups. And the two groups were either a group that were given standard of care therapy, which was assumed to be a slower, more progressive way of putting patients on triple or quadruple heart failure therapy as per the guidelines. And then there was this high intensity group where they wanted a rapid escalation of full dose therapy, and this was either ACE inhibitors, ARBs or ARNI as the first group, beta blockers or MRAs. We have talked about what those drugs are in a previous episode, so please find that and go back to that if you need a refresher on what those drugs are. But these are cornerstone heart failure drugs that have shown to benefit patients by reducing mortality or rates of death in heart failure, so dramatically reducing death rates and overall improving quality of life in the heart failure trials. And they wanted those patients to be on the full dose of those therapies by 90 days into treatment after their hospital admission. So, what did they find when they were evaluating this? Well, first of all, the trial was stopped prematurely because there was a trend or a division between the two groups that showed a significantly positive effect in those that were rapidly escalated to care. But what might have been the issues with this? Well, the group that was escalated very rapidly did have more side effects from the drugs. These were including things like higher potassium levels, lower blood pressure, worsening kidney function. So that was quite significant. In terms of serious effects, these were similar across the two groups. However, at 2 months in, when they plotted the graphs of mortality between the two groups, they found that the group doing the sort of slower introduction of standard of care were not doing as well as the group who had the rapid escalation of treatment. The mortality curves for the two were already starting to separate out, showing that the group who had the rapid escalation of triple therapy were actually surviving longer and better, than those that were having the slower standard of therapy care. Why might that be? Well, back to the original trials of these drugs, they definitely showed a significant improvement in mortality in those trials. But here's the thing, in reality, what are we actually getting out there in the real world versus a trial where obviously in a trial you've got patients who are being very closely monitored. They're under the guidance of their heart failure specialists. And in the real world, the scrutiny may not be anywhere near so good. So having a look at that, for example, Green et al. In the Journal of American Cardiology Heart Failure Group in 2024 reported that 82% of eligible patients for all four therapies as the pillars or cornerstones of heart failure treatment, 82% were eligible for them all. However, only 15% of them were ending up on all four. And in fact, about 41% were getting on triple therapy. And then not even on full doses. And this data wasn't just unique to American patients. It's similar also across Europe and Canada. And we know also that it's a similar sort of story in Australia. So even the very best sites can have rates of about 70% to achieve triple therapy. The lowest, however, the populations that weren't doing as well with their escalation of care were only on about 25% having triple therapy. So this then goes to the argument that, yeah, the drugs may be great, but if you aren't on the drugs, they can't do their thing. They can't actually save your life. They can't improve your quality of life. So, again, if you have the drugs and you don't take them or they aren't prescribed for you, then you can't get the benefit that we see in these trials. Now, quadruple therapy decreased all causes of death over 180 days, so 6 months, and reduced hospitalisation. But this required, at least in this trial, weekly visits to achieve an aggressive titration of these medications. And the trial, as I said, was terminated early because of the already strong indication of benefit. So they can reduce mortality or improve survival. They do reduce hospitalisation. Did they actually improve quality of life, given that there were more serious adverse, not more serious adverse effects, some adverse effects that were a bit higher than in the slower titrated group? Yes, in a sub-analysis in follow-up, they determined that at least 2/3 of those patients also reported improvement in quality of life in that short space of time. So I think it's fairly clear there's a couple of messages from this strong HF trial. The first is that doctors perhaps don't prescribe or titrate the drugs that are required per guideline directed therapy as rapidly as is optimal. The second is we have to watch these patients fairly carefully for any side effects of that medication whilst it's being titrated. But if we do achieve that, then we stand to get much, much better outcomes for our patients. So I hope that's helped you understand also why we advocate for more drugs and higher doses than perhaps you're comfortable with at the initiation of treatment. But this is why it's so important. And that's a very good demonstration of perhaps also the differences in the real world versus what happens in trials and the standard of care that we're all aiming to achieve. So if you wish to go see that article again, it was published in 2022 at The Lancet. It's called the Strong HF Trial. And I'll be back next time to talk about fluid management with one of our heart failure nurse specialists. So see you then.